Imagine for a second, right, that you are tasked with modifying a highly sensitive, constantly shifting ecosystem.
Ah, that's a tough job.
Yeah, but here's the catch. You can't really see it. It's incredibly close to major plumbing,
Hmm.
and it is absolutely packed with dense intersecting blood vessels.
Right.
If you make a mistake, you aren't just dealing with a cosmetic blemish. You could trigger severe infection or even permanent nerve damage.
Yeah, I mean, that is the absolute definition of a complex anatomical landscape.
Exactly.
And treating that kind of intervention like a simple, risk-free aesthetic upgrade can be remarkably dangerous.
Which brings us to our mission for you today. Welcome to today's deep dive.
Glad to be here.
So we are looking at a very specific cosmetic gynecology procedure known as the G-shot or G-spot amplification.
Right.
The core idea here is that a provider injects a dermal filler, usually hyaluronic acid or collagen, into the anterior vaginal wall. And the goal is to temporarily increase the size and sensitivity of the G-spot.
Yeah, that's the basic premise.
But, if you look online, you will be hit with an absolute tidal wave of marketing about the supposed benefits.
Oh, definitely. It's everywhere.
But today, we are setting all of that marketing aside. We're strictly focusing on the medical guardrails. We want to outline the clinical contraindications.
Oh.
So basically, who should absolutely not get this procedure and why?
It's such a vital conversation.
Okay.
Because, we are talking about a minimally invasive procedure, yes, but it's occurring in an area that demands immense respect.
Mm-hmm.
The anterior vaginal wall sits directly against the bladder and the urethra. So, introducing foreign volume into that space, well, it requires robust, procedure-specific safety protocols.
Right.
Our goal today is to help you understand the profound difference between a safe candidate and a high-risk one, down to the actual physiological level.
Okay, let's unpack this. I want to start with the most immediate black and white reasons a clinician will look at a chart and just, halt the process.
The absolute no-goes.
Exactly. We're talking about acute physical issues and chemical allergies.
Yeah.
Before we even get to the anatomy, what is actually inside the syringe?
Well, the primary substance is usually a hyaluronic acid filler, often referred to as HA.
Right, it's HA.
You might recognize brand names like Restylane or Juvederm or Nuvuvia Rose from facial cosmetics, But they are utilized here as well.
Okay.
And alongside the filler, the procedure heavily relies on local anesthetics to numb the highly sensitive tissue. So typically amide local anesthetics like lidocaine.
Right, I hear hyaluronic acid tossed around a lot in skincare. So what is it actually doing when it gets injected directly into human tissue?
So hyaluronic acid is actually a naturally occurring sugar molecule in the human body.
Oh, really?
Yeah, it's primarily found in our skin, our joints, connective tissue. And its defining characteristic is its ability to bind and hold on to water.
Okay.
I mean, it can hold up to 1,000 times its weight in water. So when it's injected as a cosmetic filler, it's this formulated gel matrix. It draws fluid into itself, expanding to create a localized temporary cushion or protrusion.
So it's like a highly targeted sponge.
Exactly like a cleanse.
Well, that makes the allergy risk quite frightening, honestly. If someone has a known hypersensitivity to HA or an allergy to those amide local anesthetics you mentioned, that's an immediate stop.
Oh, absolute stop. And the reason comes down to the vascularity of the area.
Right.
The vaginal wall is essentially a dense superhighway of blood vessels.
Mm-hmm.
If you inject an allergen directly into a tissue bed that is that highly vascularized, well, the systemic absorption is incredibly rapid.
So it hits the bloodstream immediately.
Instantly. An allergic reaction wouldn't just be a localized rash. It could escalate swiftly into severe anaphylactic shock.
That's terrifying. Okay, so what about active physical conditions? The sources mention active cutaneous disorders, inflammation, or infections at the treatment site.
Yes.
So if a patient has a yeast infection or a urinary tract infection, a UTI,
Right.
they are disqualified.
They are completely disqualified until the infection is thoroughly resolved.
Injecting filler during an active UTI feels a bit like airdropping troops behind enemy lines without an extraction plan.
Yeah.
You are basically trapping them in a hostile environment.
That is a highly accurate way to visualize it. Yeah. When you inject hyaluronic acid, you are introducing a foreign gel matrix into the tissue.
Right.
If you inject that gel into a vascular network that is already inflamed or actively swarming with bacteria from a UTI, the gel can actually serve as a scaffolding.
A scaffolding.
Yeah, like a biofilm for the bacteria to latch onto. You are literally giving the infection a physical fortress to hide inside.
Oh, wow. So it protects the bacteria.
Exactly. It makes it far more resistant to antibiotics.
So a minor, easily treatable UTI suddenly becomes a deep, localized pelvic infection.
Precisely. And furthermore, the body's natural response to infection is inflammation and swelling, right?
Right, of course.
Well, the filler itself also causes temporary swelling. So if you compound those two forms of swelling in an area that sits directly against the urethra,
Oh, no.
yeah, the tissue can expand to the point where it completely pinches the urethra shut.
Meaning the patient suddenly can't urinate.
Urinary retention. It is a severe medical emergency that requires immediate catheterization.
Well, that sounds absolutely harrowing. To round out this acute category, the sources note that temporary physiological states, like pregnancy and breastfeeding, are absolute contraindications.
Yes, they are.
I imagine that comes back to the vascular superhighway you mentioned earlier.
It does. During pregnancy, the body essentially doubles its blood volume.
Right.
The pelvic region becomes profoundly engorged with blood vessels to support the fetus, and the tissue structure undergoes massive hormonal softening.
Makes sense.
Elective cosmetic injections are simply not tested under those extreme physiological shifts. The bleeding risk alone makes it entirely unsafe.
Okay, let's transition from those temporary states, the infections and the pregnancies, to more permanent structural realities.
Good idea.
The sources point out chronic health histories and anatomical factors that completely disqualify a patient.
Yeah, and this is where understanding the mechanics of the filler becomes so critical. The G-shot relies entirely on the existing tissue structure to hold the HA gel firmly in place, which allows it to create that desired friction during intimacy.
Right, which brings us to structural issues like pelvic organ prolapse or severe vaginal relaxation.
Yes.
And here is where I get a bit stuck, honestly.
Oh.
The literature states that the procedure is contraindicated for women with severe vaginal relaxation or a pelvic prolapse categorized as stage 2 or higher.
That's right.
But wait, if a patient is experiencing severe relaxation or laxity, wouldn't they actively want something that adds plumpness and volume? That seems like the exact scenario where someone would ask for a filler.
It is a very common assumption, actually, but it reveals a misunderstanding of how dermal fillers function structurally.
Okay, how so?
Think of the HA gel not as a solid implant, but as a dense, pliable jelly.
Okay, pliable gel.
Right. For that jelly to form a distinct, firm bump, which is the whole goal of amplifying the G-spot, it needs a taut, firm wall of muscle and fascia behind it to push against.
Oh, I see. So if the tissue behind it is already weakened or sagging...
The jelly simply has nothing to push back against.
Ah.
In cases of stage 2 prolapse or severe relaxation, the foundational integrity of the vaginal wall is compromised.
Right.
So if a clinician injects 2 cubic centimeters of heavy gel into lax tissue, it won't form a firm protrusion.
What does it do?
It will simply spread out, pool, and add unstructured weight to tissue that is already struggling against gravity.
It just drags the tissue down further.
Exactly. It exacerbates the physical discomfort and that feeling of heaviness.
That sounds miserable.
It is. Women experiencing severe relaxation are routinely advised by specialists that they need functional structural support, often through reconstructive surgery or intensive pelvic floor therapy rather than a localized cosmetic filler.
Got it. Now, speaking of structural support, surgical history plays a major role in who gets approved for this.
A massive role.
Any patient with previous reconstructive pelvic surgery is generally excluded. The sources specifically point to procedures involving synthetic mesh, like mid-urethral slings or sacrocolpopexy.
Yes.
What exactly are those procedures doing that makes a future filler so dangerous?
Well, those are surgeries frequently performed to treat incontinence or prolapse. Surgeons place strips or sheets of synthetic mesh inside the vaginal walls, and they act like a hammock, literally physically holding the bladder or the uterus in place.
Right.
Over time, the patient's natural tissue grows into and around that mesh.
So the mesh becomes permanently fused with the vaginal wall.
Exactly. It completely alters the natural vascular map and nerve pathways.
Oh, wow.
So if a provider later attempts to perform a G-shot, they are driving a needle blindly into an area laced with synthetic fibers.
That sounds risky.
Highly risky. If the needle punctures or disrupts that mesh, it can cause erosion where the mesh begins cutting through the vaginal wall.
Ouch.
Yeah. And it can also introduce bacteria directly onto the implant, which, as we discussed with biofilms, is notoriously difficult to eradicate.
Right, because of the scaffolding.
Exactly. Past surgeries make the terrain entirely too hazardous for blind cosmetic injections.
We also need to look at chronic illnesses. The clinical guidelines list autoimmune conditions that affect the vulva and vagina as strict contraindications.
Yes.
They specifically mention lichen sclerosis and lichen planus.
Right. Those are complex dermatological and mucosal conditions.
Mhm.
Basically, the immune system mistakenly attacks the skin of the genitals.
Mhm.
It causes chronic inflammation, severe thinning, and really painful scarring of the tissue.
So the tissue is basically in a state of high alert.
Yes, it is highly vulnerable and hyperreactive, sticking a needle into tissue suffering from lichen sclerosis and forcing fluid into it.
Yeah.
It will very likely trigger a severe, painful flare-up of the autoimmune response. The tissue simply does not have the resilience to heal from the trauma of the injection.
Okay, that makes total sense. Now, the sources also list a history of cervical, vaginal, or vulvar cancer, specifically noting previous pelvic radiation as the disqualifier.
Yes.
If someone had radiation, say, 10 years ago, and they are completely cancer-free today, why would that prevent them from getting a cosmetic filler now?
That requires looking at what radiation actually does at a cellular level.
Okay.
Radiation therapy is designed to destroy cancer cells by damaging their DNA, right? But it inevitably affects the surrounding healthy tissue too.
Right, collateral damage.
Exactly. And one of the long-term side effects is damage to the microvascular system.
Meaning the tiny capillaries.
Yes, the tiny capillaries that supply blood to the area. Over time, this lack of blood flow causes the tissue to become fibrotic.
Meaning it becomes stiff.
Stiff, woody, and completely lacking elasticity.
Ah, I see.
Healthy tissue stretches to accommodate a filler and then heals rapidly because it has a robust blood supply.
But irradiated tissue doesn't.
Right. Irradiated fibrotic tissue cannot stretch, so if you force filler into it, you risk tissue necrosis,
Necrosis.
where the tissue simply dies because you've compressed its already fragile blood supply.
Oh, wow. Okay, so we've looked at the acute chemical risks, the structural physics of the tissue, and the long-term cellular damage from things like radiation.
Yeah, quite a list.
But let's shift the discussion to something completely different. We really need to talk about functional mismatches and experiential exclusions.
Yes. The psychological side.
Because sometimes the physical anatomy is perfectly healthy. The tissue is robust, there is no infection. But the underlying reason the patient is seeking the procedure makes them the entirely wrong candidate.
Right. Navigating this requires a clinician to step away from the physical examination entirely and deeply assess a patient's sexual history and personal expectations.
And the clinical texts are highly blunt about this.
Very blunt.
They state that the G-shot is absolutely not for women who have never experienced an orgasm in their life, a condition often referred to as primary anorgasmia.
Yes.
I have to admit, I read that and immediately thought, wait, isn't the whole point of this shot to help someone achieve an orgasm?
That's what people assume, yeah.
So if they never had one, wouldn't an amplifier be exactly what they're looking for?
Well, if we connect this to the bigger picture, human sexuality is not a simple mechanical switch. It is a vast symphony of neurological, hormonal, psychological, and relational factors. I mean, the brain is effectively the largest sex organ.
Right.
The G-shot does only one highly localized thing. It temporarily adds volume to a very specific millimeter of tissue on the anterior vaginal wall to increase physical friction.
So what does this all mean for a patient with primary anorgasmia? Is this just a mechanical fix being applied to a systemic issue?
That captures the danger perfectly. Yes.
Okay.
If a woman has never achieved an orgasm, the barrier is almost never the physical circumference of one specific internal nerve cluster.
What is it usually?
The barrier is frequently psychological anxiety, a lack of communication with a partner, or often simply a lack of foundational personal discovery about how her own neural pathways respond to stimulation.
So the shot isn't going to teach the nervous system how to climax.
No, it cannot magically create a neurological climax out of thin air if the foundational pathways of arousal are not already established and functioning.
That makes total sense.
Augmenting the physical size of the tissue without addressing the holistic reality of the patient just sets them up for profound disappointment.
Right. Building on that concept of systemic versus local fixes, the guidelines explicitly state this procedure is not a cure for sexual dysfunction, low libido, or hormonal drops.
Absolutely not.
So, if you are listening to this and you are experiencing a severe drop in libido because you're going through menopause or because you are navigating intense chronic stress,
Yeah.
It seems crucial to understand that a hyaluronic acid injection is not going to change your hormone panel.
It will not alter your estrogen levels, and it will not lower your cortisol.
Marketing can sometimes blur the lines, suggesting that physical friction equates to desire. But if the baseline hormonal desire is absent, a localized mechanical amplifier is an inappropriate, completely ineffective intervention.
The sources also highlight psychosexual disorders, specifically pointing to vaginismus, as a reason a patient might be heavily cautioned against or even refuse the procedure.
Right. Vaginismus is a deeply distressing condition. It sits right at the intersection of physical reflex and psychological anxiety. It involves the involuntary tensing or severe contracting of the pelvic floor and vaginal muscles, and it often makes any kind of penetration incredibly painful or even physically impossible.
Knowing what we discussed earlier about how the filler stretches the tissue, injecting volume into a muscle bed that is already involuntarily spazzing sounds, well, counterproductive.
It can be actively harmful. Yeah. The localized pain of the injection needle itself, combined with the sudden sensation of added volume and pressure in the vaginal canal, it could trigger even more severe muscle spasms. It reinforces the brain's association between the pelvic region and pain.
Oh, wow.
Yeah, potentially heightening the patient's anxiety around physical intimacy. Patients navigating vaginismus benefit from specialized pelvic floor physical therapy and psychosexual counseling, not fillers.
Okay, here's where it gets really interesting, because this leads us directly into the psychological standards in cosmetic surgery.
Yes, the ethical framework.
Right. A skilled provider isn't just looking at the physical chart. They have an ethical obligation to evaluate the patient's motivations.
Medical ethics demand it. Providers across the globe operate under strict psychological screening guidelines, such as those published by the British Association of Plastic Reconstructive and Aesthetic Surgeons.
Commonly known as BOPRIS.
Exactly, BOPRIS.
Looking at the BOPRIS standards mentioned in the sources, practitioners must refuse to undertake the procedure if the patient has unrealistic expectations about the surgical outcome, and if that discrepancy cannot be resolved during the initial consultation.
You see, we operate in a society that aggressively markets the idea of effortless, cinematic sexual experiences.
Totally.
If a patient sits down in a consultation room and expresses a belief that a 15-minute filler injection will miraculously repair a failing marriage,
Right.
or cure a deep-seated depression regarding their overall body image, a responsible surgeon must recognize that as a profound red flag.
Because the physical outcome of the syringe will never, ever meet the emotional weight of what the patient is hoping for.
Exactly. The procedure will inevitably, quote-unquote, fail in the patient's eyes. Not because the filler didn't work anatomically, but because a localized injection cannot repair interpersonal trauma or treat clinical depression.
The guidelines also require providers to refuse treatment if the patient has a history of repeated cosmetic procedures in one anatomical area, accompanied by evidence of ongoing dissatisfaction.
Yes. That is a primary diagnostic indicator for body dysmorphic disorder. If a clinician reviews a chart and sees that an individual has undergone multiple labiaplasties, aggressive vaginal tightening procedures, and is now seeking a Jew shot, yet they report being continually unhappy with their physical body, the underlying issue is not the physical anatomy. The issue is a psychological distortion in how the brain is perceiving the body.
So performing another physical procedure on someone experiencing that distortion just feeds the cycle.
It causes active harm by validating the dysmorphia.
Right.
The final overarching point in those clinical standards is that if a patient's mental health history reveals deeply emotional psychosocial motivations, they require psychological screening and support. A provider must protect vulnerable individuals from utilizing a physical invasive procedure in an attempt to solve an emotional struggle.
So to bring all these complex threads together for you listening, the G-Shot is a highly specific, elective, and temporary cosmetic procedure focused on amplifying the anterior vaginal wall. It is definitively not for you if you are currently navigating an active infection like a UTI, if you are allergic to hyaluronic acid or lidocaine, or if you are pregnant.
Furthermore, the physics of the filler require a sturdy foundation.
Which means it is not a viable option if you have severe pelvic prolapse, complex surgical histories involving synthetic mesh, or cellular damage from radiation.
Correct.
And perhaps the most crucial takeaway, it is not a magic bullet. It is an anatomical amplifier, not a cure for complex hormonal changes, deep emotional trauma, or lifelong functional realities like primary anorgasmia.
It requires a remarkably healthy, stable physical baseline and a thoroughly realistic, grounded psychological mindset.
Before we wrap up today's deep dive, I want to pivot just slightly to something you brought up earlier about the anatomy itself.
Sure.
We've spent this entire time talking about the strict rules regarding who shouldn't get their G-spot amplified. But looking at the broader research, there's a fascinating scientific debate happening right now about what the G-spot actually is.
Oh, it's a huge debate. And it raises an important question, really highlighting how rapidly medical understanding evolves. In the 1950s, Dr. Ernst Greffenberg described the area as a distinct, standalone, highly sensitive zone on the anterior wall.
Famous G-spot.
Right. But modern anatomical mapping is shifting that perspective dramatically.
Yeah, the sources indicate that many modern anatomists suggest the G-spot isn't a separate, distinct button at all.
The prevailing modern theory, which is supported by advanced imaging and dissection, is that what we historically called the G-spot is actually just the internal underlying network of the clitoris.
Wow.
Yeah. The external glands of the clitoris is only the very tip of the structure. Its legs, or crura, wrap deeply internally around the urethra and the vaginal wall.
So when pressure is applied to the anterior vaginal wall, you aren't stimulating a unique organ. You were just pressing against the internal roots of the clitoral network.
That is the current anatomical consensus, yes.
Okay, if the G-spot isn't a separate entity, but just the internal side of the clitoris,
Yeah.
what does that mean for the future of procedures like the G-shot?
Well, that is a brilliant, provocative thought to consider. If the entire premise of the procedure is injecting filler into the vaginal wall to amplify a specific spot, but we are actually just creating a cushion that presses against the internal clitoral network,
Right.
how might future discoveries completely redefine the candidate criteria? Will we discover that a dermal filler is completely ineffective for some individuals simply because the unique internal shape of their clitoral network sits slightly deeper or wider than average?
It completely reframes the mechanics of the
It
procedure.
really does.
It implies we might be treating an area based on a map drawn in the 1950s, while the actual terrain is far more complex.
Exactly.
As science continues to map this internal nervous system with better precision, those medical guardrails we just spent the last 15 minutes unpacking are going to have to evolve.
Without a doubt.
Well, thank you for joining us on this deep dive into the physiological realities of cosmetic gynecology. Keep questioning the marketing, keep exploring the science behind the claims, and we'll catch you on the next one.